Hi, it's the Nursing Professor here for another episode of Fundamentals on Friday. So today we're going to actually talk about wound healing and skin. We know skin is the largest organ of the body, and so whenever it's compromised, it puts us at a higher risk. All right, so 3 layers of skin. Just a reminder, epidermis, top layer. Dermis is that middle layer. Subcutaneous is a little bit further down. We need to be aware of that as we're talking about wounds. There are many factors that affect our skin integrity. They include just the aging process. Skin tends to get a little more fragile. Mobility, people aren't changing positions that often. Nutrition, hydration, moisture, people who are incontinent, people with sensory problems that they don't get the signal that they need to change positions. This is why we assist people in changing positions every 2 hours. And this is something we can also delegate. All right, those with impaired circulation, they can end up with what we call stasis ulcers, where that venous return is compromised, and you see these people with a lot of edema in their lower extremities. That edema can lead to chronic ulcers in the lower extremities. A fever can actually have an impact on the skin as well, because of course you have increased metabolism, person is sweating, making their body moist and wet. All right, so moving on, we have both acute and chronic wounds. Acute meaning that they last typically a very short term. They may be a surgical wound, post-op wound that it heals and that's it with it. Or we can have chronic wounds that are those wounds that come and go, like a stasis ulcer, where you have that poor venous return. They get better, they go back. Stage 4 wounds, sometimes they get better, they look healed, but they're never considered totally healed. They're always called a healed stage 4 wound, because that skin is always at risk for further skin breakdown. So we have 3 different wound healing processes I want to talk about. The first one is primary intention. This is when you have a wound that's a surgical wound, has a nice clean cut. Those wound edges are approximated. That means that the wound edges are brought together by something like sutures, staples, glue, steri-strips, those types of things. And the wound heals. Usually has a really nice remnant of a scar. It's not usually jagged and have any type of problems there. Then we have secondary intention, and this is where we have wounds that we want to heal from the inside out. And so we use various dressing changes in order to promote that wound healing, so that the tissue continues to heal until it gets to the top, and then that actually closes over. Next, we have tertiary intention. And this is when the granulating tissue is actually brought together. It heals from the inside out, gets to the top, and then sometimes it requires some help with closing that top layer of skin. Okay, and so whenever we're using staples, and we use staples quite frequently in surgical wounds, you need to make sure that you know how many staples are actually put in, because that is the number that needs to come out. And frequently, as wounds heal, sometimes those staples get hidden. So you want to make sure that if 8 staples are used to close the wound, that 8 staples are actually removed, because I've seen it frequently where one of those staples stay in there, and it is a nuisance. It creates a lot of discomfort for your patient. There are several different types of wound drainage that we have. We have the serous exudate. It's kind of straw-like colored. Then we have serous drainage, which is bloody drainage. We have serosanguinous, which is a combination of the two, so it's both bloody and straw-like colored, and typically that is as your wound is actually healing. Then you have purulent, which is yellow pus-like drainage, really thick, usually a sign of infection, and purosanguinous, also typically a sign of infection. So it contains both blood and pus. All right, so some complications of wound healing we want to think about is hemorrhage. That's when you have a lot of bleeding. Infection is when there's little bugs that get up underneath there and the wound has difficulty healing. Dehiscence is when you have a wound that literally pops open. Frequently it happens in the abdominal area where a person has a midline cut. And so because we use our abdominal muscles so much to change positions, to cough, to sneeze, to talk, to breathe, then sometimes that wound actually busts open. And so when it does that, person needs to get to the emergency room such that that can be taken care of. Sometimes the healing to that is to leave it open, but they need to be seen. All right. And one of the worst things that can happen is evisceration. And that's when that abdominal wound busts open, but not only that, then some of the internal organs start to show themselves outside of that wound. So like you might see some of the intestines or something like that. That person needs to get to the hospital right away. And so we want to make sure that we teach our patients upon discharge that if they notice any of that, then they should seek medical attention right away. So now we're going to use a nursing process as we're talking about wounds and wound healing. So in our assessment, we're going to use a couple of tools. One is called Braden, and Braden assess mobility, what the skin looks like, what the hydration, nutrition is, if the person's incontinent or not, gives them a score, and then we will follow that. And we compare that usually week to week to see if that wound is getting better or the person is getting less risk of skin breakdown. We also have what's called the push tool, and the push tool is also a very good assessment tool that we actually use to determine if that person actually is at risk for further skin breakdown or not. When we're measuring wounds, we want to make sure we're going up and down, lengthwise, and then across width. We typically measure in centimeters, so remember it's up and down, side to side. That way everybody gets the same measurement. You want to be able to chart location, if there's any type of drainage, what that wound looks like, especially the wound bed, if there's any redness, swelling, pain, all of those types of things. For labs, we want to make sure we're looking at platelets because that's how blood clots, and white blood cells, which could be an indication of infection. Then we move on to the nursing diagnosis. Typically it's alteration in skin integrity or at risk for compromised skin integrity or tissue healing, one of those. Okay, and then our interventions, of course, includes whatever wound care that we have, removing the old dressing, putting on a new dressing as prescribed by the provider. As an intervention, sometimes our wounds will require what we call a wound vac. It's a product made by 3M. It is excellent. It has negative wound pressure, and that actually promotes healing. And so you just go on YouTube and take a look at one of those videos and you'll see exactly what that is. Because typically the surgeon puts it on in the OR, but nurses maintain it and continue to change it even when your person goes home. And they really can heal some of the most incredible wounds. All right. All right, so what did we have? We did the assessment. We came up with nursing diagnosis. Our plan, of course, is to heal this wound. Our interventions were all those things that we just talked about. And there's various types of dressing changes that you can do. And then we evaluate. We determine how effective our interventions were. And so that might include comparing like your Braden score 1 week or your push tool 1 week to it the next week. And hopefully the risks are being minimized and the measurements of your wounds are actually getting smaller. All right. And so I hope that helps with you when you're thinking of skin and wound care. Like, share, and I will see you next video. Bye for now.